basically the reason you are only 30% of results with deep endo at that time is because of the camera. You don't have a good camera at that time. That was impossible in order to see. So when we talk, when
I was better than camera in those days.
I know, but you can not. I mean, not your eye. So let's talk a little bit about something that usually we never discuss when we are in the congresses related to endometriosis. And when you talk about endometriosis, usually we talk about young people that try to maintain their fertility. So we're not going to talk about hysterectomy, but sometimes I think that we have to talk about the limits of our surgery. And even in younger patients, we have to talk about when to decide to make surgery. Radical surgery, which means if you go into the up-to-date total hysterectomy with BSL, is the definitive treatment for severe endometriosis. But the question is, should we do it in a regular basis? And the answer is no. No, why? Because most of the people are very young people, social, cultural, because of they are young and metropolitan women. The delay of the family is I mean, it's normal, and because there is a lot of professional career for the first years of most of the people, and then they want to preserve the fertility. So the reasons not to perform hysterectomy are those that it's basically the fertility, but be aware that disease is becoming more aggressive, and especially as Lon probably will show you the disease is not only becoming more aggressive, is getting more and more young patients. So when you look at the things like this, and you see, you know the quality of picture here? It's different. So this is a complete frozen pelvis. That is nothing. That you have to try to discover where are things, where is the ureter, what is the ovaries, where are the, I mean, everything that the tubes are coming here, the rectums over there, and at the final, what you're going to have, all the this dissection, like in, or more difficult, like in a cancer. You get everything exposed, even the rectum over there. These are the ovaries. I have done a salpingectomy, bilateral salpingectomy, and at the end, this is the result of a huge endometriosis treated by laparoscopy. Of course, I will release the ovaries at the end of the operation because the patient needs to go to IVF. So what are the questions for hysterectomy on severe endo? Well, there is some indication that depends on the patient desire. If the family planning is completed and if the symptoms are incapacitating and persist after surgical or medical therapy, you will hear women saying too much and too many years of suffering. And because more and more patients are aware of the situations, they can have fear of the progression of the disease. And this means bowel perforation, this means kidney failure, this probably means cancer, and some other things that we can discuss. But besides those two that are related to the patients, we have to think about the surgical limits to resection of the disease, which means that is the doctor's indication, the surgical indications that we have to discuss. So let's discuss something that usually we don't discuss on the endometriosis congresses or courses or whatever, surgical limits to the resection of the disease and the surgical indications in spite of the age of the patient. So oophorectomy or not, there is almost no data about that. The only paper I could find was from 1973, and there is only one study suggesting that a higher recurrence rate without BSO, only with hysterectomy, and there is absolutely no data suggesting there is an increased risk with HRT. So limits. When we're going into the rectum, the sigma, and we have these type of lesions on the rectum and the sigma that can be unifocal or multifocal or something like that, that it looks like a cancer, and you want to remove all the bowel, so you have to think about what you're going to do it. There is a significant risk of perforation, so there is probably a significant risk of peritonitis. Time of perforation is not predictable. Nobody can predict if any lesion is going to be taking like 6 months or 10 years or never in order to do a peritonitis. And the other thing is the lower and the deep the tumor, the higher probability for perforation, and also a great risk for colostomy if it is a very deep tumor, and maybe the colostomy can be definitive. And the other thing is the multifocality of the disease that can be during the surgery, and it's easy because in order you don't just remove 5 centimeters of the sigma, you're going for 10, but the problem is after surgery and you got a new nodule of endometriosis. So how lower can we resect that? Well, at least in the last year, starting in Lisbon, then Atlanta, then Istanbul, then AAGL, we almost agree that we should not go to the level of the inferior rectum. So probably at the end, we have to think that if you have cases like this, and what I want to show you is when you have a dissection like this, that you still have tumor here, but this is vagina, this is rectum, at the level of 3 centimeters from the anus. You cannot do a resection here because you have to do a colostomy to the patient, and probably it's going to be a definitive colostomy, because to do a reanastomosis here is going to be very, very tough. So what to do in those situations after you solve the fertility of the patient? So probably the safe limits to the rectum resection will be 6 to 7 centimeters from the rectum, probably. And we try to agree on that. And what about the bladder? When you get this on the trigon, you have the infiltration of the ureter, you have the infiltration of all the trigon. What to do? Are you going to do a radical cystectomy in order to put the ureterals into the bubble and do a poor quality of life for everybody, even for a very young patient? This is one of my patients, and I decided in this patient, after discussing with her, to do an hysterectomy. And I could see during 8 weeks lots of small amounts of tumor coming into the Foley catheter, and you have to remove sometimes the Foley catheter in order to put another one. So invasion of the trigon, avoid radical cystectomy, and talk to the patient and say, listen, if you want into a radical cystectomy, this is going to be a hard operation, and a hard operation with a lot of complications. So let's discuss a little bit about hysterectomy and BSO. So about urethral endometriosis, again, there is another discussion. We always talk about if the endometriosis is extra or intra urethral, but in my opinion, this is not important. The important thing is what's happening here. This is 25 years patient trying to get pregnant and with bilateral hydronephrosis because you got here and here a huge lesion of endometriosis. So what to do in these cases? So in my opinion, it will depend on the kidney damage. We have to start thinking about if you have to do this operation or not. And there is no data, so now you cannot judge based on the experience of other people. And probably when you get the GFR more, this is wrong, more than 20 mil by minute, probably it will be better to remove the disease and avoid the complications of getting the ureter involved, and then you have a complication, and then you have to do a sausage or do some other kind of complicated surgery, and the quality of life again of a young patient is going to be terminated for the rest of their life. If you look at this, this patient was with 12 before I operate on the ureter, and now she's got 17.9, almost 18. I'm still following her in order to see if I'm going up. So we still don't know where are the limits in order to avoid very complicated surgeries related to endometriosis in young patients and say, listen, this is going to be very difficult. You can get this and this, and it's better to start to discuss something that usually we never discuss because they are young patients. So when we talk about the inferior hypogastric plexus, again, that is another thing that you have to think. If you got some disease like this, and there is a lot of them, and here you see the ureter that is, it was already invaded by the disease. And you have to go down because there is a lot of disease on here. I'm trying to separate the ureter from the pararectal fossa, where you get the disease completely involving the inferior hypogastric plexus. And you know you have to remove the disease. So you have to go and cut. And in this case, it was unilateral. So I took the decision in order to remove everything around the ureter over there that I'm afraid of damage. Probably you'll say that there is a little bit of disease over there, but I don't know. I do prefer to leave a little bit of disease, and I'll tell you why in a couple of minutes. So the key question is trying to avoid the most important structures and then remove the what you have to remove in the involvement of the inferior hypogastric plexus. And the reason for that is if you get radical surgery in such situations, you're going to have bad complications because you can have a lifetime self-catheterization of the bladder in a young patient, an absence of orgasm, a chronic impairment of defecation. So how far should we go in surgery? Again, no landmarks. So each patient, different reactions. Even when you do it only in one side, we know if we are going in both sides, the patient will get everything of this. But even when you go just in one side, like you saw in the film, there are publications already saying that still the patients have some complications like this. So we don't have any limits, and we don't have any data. So there is no data available for radicality. So again, do we have to think, or at least we have to discuss with the patient about IST plus or not BSO. I'm still in time because I have 40 minutes, don't worry. So, ascites. This is endometriosis ascites. I'm controlling here on the computer. And what you got in this case? What to do? There is no publications of ascites, endometriotic ascites, with a patient that can be pregnant after that. But believe me, this patient is pregnant right now with 14 weeks. I'm lucky, so if she's delivery, I'm going to publish this case because it's, as far as I know, is the first case with endometriosis ascites that became pregnant after the surgery. Of course, there is, again, no data. There is different results, as I told you before. After surgery, if there is no fertility, if there is recurrence, again, you have to think about yeast with BSO or not. So what about this? What about diaphragmatic endometriosis, when you can see the lung through the hole, when you can see I mean, even you can see the heart through the lungs on the diaphragmatic endometriosis, and you never know when this patient is going to have hemothorax or anything related to, and do emergency surgery on the lung, in order to avoid this. So you never know when you have to resect that or not. And if the patient asks you, doctor, am I going to have any complication with my lung in the future? You have no answer. Because again, you don't know when, like in the bowel, you don't know when it's going to get the perforation. Here, you don't know when it's going to have pneumothorax or hemothorax. So when you talk about diaphragmatic endometriosis, the risk of lung collapse is unpredictable after pulmonary or combined surgery, laparoscopy with thoracic, no fertility desire. If there is recurrence, again, you have to think about yeast plus BSO. What about adenomyosis? That is easy. If there is a diffuse, it's different from focal. We don't know the real impact of adenomyosis in infertility, because after surgery of severe endometriosis, I got a lot of patients that get pregnant, even getting severe adenomyosis. If it is focal, probably you can do adenomyomectomy. If it is diffuse and no fertility after some years, and the progression of the symptoms, especially pain and menorrhagia, then you have to think about yeast plus BSO. So in conclusions, reasons and indications to perform hysterectomy. Patient desire again. The family planning is completed. That is easy. That if there is incapacitating symptoms that persist after surgical or medical therapy. If there is a progressive adenomyosis with pain and menorrhagia, and if the patients are aware of the complications of the disease progression on each organ. And again, the clinical surgical judgment on the risks of disease versus the specific issues like rectal location to load, the kidney function, the trigon location, the inferior hypogastric plexus damage, the recurrent pneumothorax, and I can put it here, the cancer, because there is a relationship between cancer of the ovary and endometriosis. Let experienced surgeons on endo make the right decision. And the experienced surgeons make the decision is difficult to do because, again, there is no guideline, there is no data, there is no publication, there is only meetings like this in which we can talk at the dinner. And, hey, Ari, tell me, I got a patient like this, or, I don't know, David Redwine, I got a patient like that, what do you suggest? So there is nothing except our dinners. We have a little bit of wine on in the meantime. So follow and trust the few experts. Thank you very much. 19 minutes.